This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 27, IV Access. After completion of this chapter, you'll be able to understand these concepts: fluid balance, indications for IV access, methods for venipuncture, complications of intravenous access, techniques and strategies for pediatric phlebotomy and intravenous access, and alternative access point and central venous access devices. Intravenous access and paramedics. Public distinguishes a paramedic from the basic life support providers by the ability to start IV access. An IV permits a paramedic to give pain medication and other life-sustaining drugs. The human body is partly made up of water, and distribution are across three compartments. The intravascular space, which is in the actual vessels, the intercellular compartment, which is inside the cells, and the extracellular compartment, which is everything that's in between. Extracellular compartment would be composed of both the space in between the cells and the vasculature, and that what is in the vasculature itself. Medical versus trauma. Important concept, rationale for obtaining IV access. And there's two thought processes on this. There's medical and trauma. Medical lines, sometimes called lifelines, are means of giving medications directly into the circulation in case your patient crashes or has an untoward effect towards something. The trauma line is inserted in the vascular space so the intervascular volume can be replaced and homeostasis restored, like for bleeding. Sources of fluid loss. The book talks about insensible loss, and that's the volume of fluid that is lost from the body in the form of perspiration off of the skin. Also, the amount of fluid loss through like breathing and water vapor. The amount of fluids normally lost, both sensible and insensible losses, can be accelerated by disease. Generally speaking, this is about 1.1 liters daily. Past medical history. Number of diseases can give us complications as far as past medical history goes, or in their medical history. Example of this would be diabetes insipidus, which can give the patient life-threatening dehydration. Talked about this. Emphysema, persistent high breathing rates causes dehydration from water vapor loss. CHF and fluid shifts can also make a person cellularly dehydrated. Liver failure, protein osmosis. Liver produces most of the proteins for osmosis in the body. There would be drastic fluid movements without them. Hyperglycemia as well. Example of this is you have large molecule substances in the vascular space, and water will go towards it. So people in DKA and that are hyperglycemic are dehydrated, and they're dehydrated instead of their cells being all fluffy with the normal amount of fluid. They're kind of like this. Physical exam for dehydration, pretty much in the head to toe. We start looking at things that would give us signs of possible dehydration. Decreased level of responsiveness, tachypnea, tachycardia, hypotension, postural hypotension, lack of luster in the eyes, dry cracked lips, etc. The neck, the jugular venous area, if they have flat jugular veins when lying down, that would also be a key indicator of dehydration. Urine output, have they been peeing normally and what color is it? Oliguria is decreased urine output. Normal urine output is 30 milliliters per hour. Oliguria would be down to 20 milliliters per hour. Hospital setting, the gold standard for fluid balance is pretty much the patient's weight. Intravenous fluids, either intended via intravenous routes for therapeutic medications or to be therapeutic in themselves in the case of trauma for like fluid replacement. We use things like normal saline and lactated ringers for the trauma patient. In the medical situation, generally we keep it running TKO unless they require fluid bolus because they are dehydrated. Tonicity. Solution's ability to alter the cell internal fluid balance. And we're going to talk about tonicities on the next page, isotonic, hypotonic, and hypertonic one more time. But if we have inside the vascular space and inside the cell, and we put something that's very high in solute concentration, it's going to pull fluid towards it, and thereby pull fluid outside the cell and into the vasculature. Wherever the high solute concentration is where the fluid's actually going to go to try to thin it or balance the whole fluid thickness in the system through diffusion and osmosis. And this is figure 27.1 in your book, and there's 3 tonicities here listed, isotonic, hypotonic, and hypertonic. We're going to talk about isotonic here being first. The isotonic is everything is balanced, so both the solute concentration, that's where I put those big green things, and the water molecule concentration are equal both inside and outside the cell. So whenever we look at this, the equation is kind of balanced. There isn't an area to where there's a higher concentration of one substance at all. And B, that was A that we just talked about, and that's isotonic. Hypotonic solutions. In a hypotonic solution, there is more water molecule on the outside of the cell than there is on the inside of the cell. So what that causes is a net movement of water inside the cell. Reason being is because it's just trying to balance the equation. So until all of these parts are equal, the fluid will rush inside the cell. Now this can actually cause the cell to burst if the tonicity is low enough. Last but not least here, this is a hypertonic solution. And if we'll notice the green areas here, there's a lot more large solute molecules on the outside of the cell than there is on the inside of the cell. So what that's going to cause is that's going to cause a net movement. I'll change colors here so we can kind of see this a little better. A net movement of fluid to try to balance the tonicity outside the cell. And what that causes is the cell was like this normally, nice and round. It crenates because it pulls all the fluid out of it. Intravenous fluid administration, important concepts. As far as IV solutions go, whenever we put this together, and this is going to be a skill, so we're going to briefly go over it a little bit, we need to check our IV solutions. In the administration set, we need to be sure that we have the appropriate administration set. Please go over this material in your book. And then prepping the intravenous administration set. After an inspection, and it needs to be a methodical inspection, we pick the tubing. We will actually put the administration set and the IV bag together, and that will prepare our IV set for administration. This is an administration set. Drip chamber up here. Spike attachment. This is what goes into your bag. This is the roller clamp that will clamp it off. Be sure to clamp this off beforehand so we don't get messy. And these have multiple ports on them for adding medication. And then this is the lure lock at the end that will attach to the patient's IV cannulation. An intravenous solution warming sleeve, figure 27.10 in your book, and then a blood infusion set. The blood infusion set has one little extra thing here. It has a filter in here, and most of the time it will have another Y compartment coming off of it. And what that is so that they can hang a saline bag here and then a unit of blood here, kind of mix them together and flush this out and keep things kind of moving. Intravenous access. Again, this is going to be a skill, but important concepts to understand about this skill. Peripheral venous access devices, what access devices you actually have. The categories of venous access devices, where there's over the needle butterfly, needle over the catheter, be sure and be familiar with those. Needle safety, be sure and do not get stuck. This is the easiest way to expose yourself to HIV and other bloodborne pathogens. And then site perspiration and disinfection. I'm sorry, I forgot one here. Peripheral site selection. Be sure and choose a site that you can easily see. Some patients you can't easily see their veins, so be sure that you have an appropriate site before you start sticking on your patient. And then the preparation and disinfection, be sure and clean off the area nicely. Again, this is a skill, and we'll discern this in psychomotor lab. Important concepts continued on the same topic are going to be the venipuncture itself. Be sure you are in the lumen of the vein whenever you provide the venipuncture. Decide on whether this is going to be a continuous infusion or an intermittent infusion. If you're going to give them, like, say, a couple of fluid boluses, that would be intermittent, or we're just going to open it wide up or deliver to them a medication of X amount of milliliters over a certain amount of time, then that would be a continuous infusion. Securing the IV catheter, be sure it's taped down very well, and adjust the infusion rate to whatever you're trying to do or whatever is appropriate. Gaining IV access in the cephalic vein. This is the actual venipuncture here shown. Once you're gaining IV access in the dorsal arch of the hand, these are probably some pretty good spots to actually get an IV. And gaining IV access in the external jugular vein. There's his chin right there. Big, large vein. There are complications to each of these. This one here being the most complicated. If you start too low, very simply, you can cause a collapsed lung if you get a little aggressive with your sticking. Tape and a chevron device, you'll have to practice this. The easiest way to do this is to practice it again and again until you get it correctly. Or you can use dressings, omega loop, or nice transparent version of membrane dressing here. Be sure that you provide a couple of loops. Again, what this does is if the IV is pulled, it'll pop this off instead of pulling out your IV. Flow control device here. Be sure it's clamped down all the way. Intravenous injection. This is also a skill. Important concepts on this are going to be the IV access for rapid injection in case we need to give somebody a bolus of medication. If there's any kind of obstruction of the intravenous flow, be sure we have a patent IV. Complications of intravenous infusions is we can get infiltration. I got a nice little picture of that on the next slide. Infusion-induced hypothermia, and that's because the fluids themselves are room temperature. So if you're running a bunch of fluids in, very simply, it can bring down the patient's temperature. And then removing intravenous access. So whenever it's all done, you got to undo everything that you've just placed onto your patient. Example of this, all of this tape here would need to be removed while pulling the IV out quickly. This is figure 2728, grossly contaminated solutions. Solutions should not look like this at all. This is a contaminated solution. This here is what they should look like. Clear, no crystalline forms, no cloudiness. Nice inspection list on there and also on our skill sheets. Intraosseous access, and this is also going to be a psychomotor skill. Important concepts on this: anatomy and physiology of the long bones. Please be sure and keep your appropriate locations where the IOs go. The various types of interosseous devices. The types that we have readily available in EMS are the big one, which is the bone injection gun, the Easy IO, and a Rashidi pediatric needle. Indications and contraindications. If somebody has broken bones, or the bone that you're putting this in is broken, that would be a contraindication. There's some other ones as well. Osteoporosis may be a consideration. Osteoimperfecta is another consideration of a contraindication. The interosseous placement, this is going to be various depending on where you actually place them. Bone injection guns would go into the tibial area. Easy IO, tibial humeral areas, and then your medication administration. Now, this has a list of IO medications. However, Easy IO states that anything that can be placed IV can be placed via the IO line. And this is list table 27.1, list of IO medications that you can easily put in play. Phlebotomy. Important concepts. The pediatric phlebotomy, very simply, a kid, you have smaller veins. Blood cultures, when the patient has a fever, the paramedic may be drawing blood cultures. Most of the hospitals are now on a type of sepsis protocol. So they may actually, don't feel offended if they actually redraw the blood cultures, but they have to be done in a specific fashion to fit within their sepsis protocol. Pediatric intravenous access, always keep in the back of your mind that you may need to go to the IO because you cannot obtain IV access. If it is life dependent on an IV access to initiate ALS protocols, then initiate very simply after 2 tries, I believe, is most protocols on this. After 2 tries that are unsuccessful or 90 seconds has elapsed, then go ahead and initiate an Intraosseous Access device. The Easy IO also comes in pediatric versions, or you can use a manual Rashidi needle. Scalp vein access is also a possibility. Butterflies are the easiest to do there. Whenever you make access to the IV, you can tape the butterfly down on the pediatric side. Try to have a cup or something, a styrofoam cup, so that it'll kind of protect the IV site. We'll go over that too in pediatrics. Central venous access, this is not really a current skill, but in the central venous types, this book will talk about different types of central venous access. Field place central venous access devices, there may be various types. The Easy IO is the easiest way to initiate central circulation. Under a pressurized bag, the fluid and the drug would be accessible to the patient within seconds. Access of central venous access device, how we would actually access the device itself. Very simply clean off the area if we need to administer medication to it off of, like, say, a triple lumen or a femoral vein. And then implanted devices. Implanted devices are for long-term venous access, and they require special needles. So be sure you have the appropriate needle when accessing a site. Current protocols generally require us to call online medical control to access such devices. In conclusion, venous access for both fluid replacement and medication administration during an emergency is critical. The paramedic skill in obtaining venous access is often regarded as an indicator of the paramedic's capability. Without venous access, very little can be done to alleviate patient suffering and pain. References for this chapter can be taken or can be found in Richard B.B. Professional Paramedic, Volume 1, Foundations of Paramedic Care, First Edition, pages 552 to 597 of Delmar Learning. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.